Thank you, everyone, for coming tonight. My name is Dr. Summer Odom. I work in Student Health Services here at Albany State, and I also teach part-time in the nursing department. I also tutor for the T's. If anybody still needs to take the T's, please see me after, and we will get you set up with our study group. But tonight, we're very honored. We have a wonderful speaker, and I'm honored to be in the room with you tonight to hear the message of this keynote speaker. The community of Southwest Georgia is our home. With that being said, I truly know that each of you will walk away with you tonight countless health pearls of statistics and solutions that will encourage us to move forward and directly impact our community of Dougherty County and the surrounding areas. Please turn your attention to our current nursing chair, Dr. Andrea Dozier, as she presents the keynote speaker tonight.
Good afternoon. Remy Hutchins is a registered nurse from Tampa, Florida. She earned a bachelor's in nursing from Florida A&M University and a master's in public health with a concentration in communicable disease from the University of South Florida. With almost 20 years of experience as a professional nurse and public health practitioner, Remy has worked in many leadership roles. For the past 10 years, she has served as the Infectious Disease Program Director at the Georgia Department of Public Health, District 8-2, which consists of 14 counties located in Southwest Georgia. Remy manages a multidisciplinary team dedicated to decreasing the rates of tuberculosis, HIV, and emerging infectious diseases such as COVID and monkeypox. She also works to address health equity issues that impact the health of Southwest Georgia. Remy is an active member of Delta Sigma Theta Sorority Incorporated, Jack and Jill of America Incorporated, president of the Southwest Georgia FAMU Alumni Chapter, and she was recently selected for Leadership Albany Class of 2023. Ladies and gentlemen, Remy Hutchins.
Thank you so much for the introduction, and thank you for the opportunity to come before you all today to speak. I'm elated to be here today, and I don't take it lightly, so thank you. I'm a little taller than everybody else. Can you hear me? Okay. Well, I can't see now. Okay. So, as in the introduction, it talked about I work for the Georgia Department of Public Health. And what that really means is I'm an extension of what you may remember or know as your local health department. Your local health department, there's a health department in every single county in the state of Georgia. And those different health departments are grouped into districts. And the little red area at the bottom of this map in Georgia represents Southwest Georgia. And there's about 300,000 citizens that live in this particular area. And our mission is to prevent disease, injury, and disability, promote health and well-being, and also prepare for disasters. That's the overall mission of public health. So before I frame my conversation, the first thing I want to talk about is health equity and equality. And those words are often used interchangeably, but they really mean two different things. So if you don't walk away with anything else from this presentation, if infectious disease is not your thing, you can at least have an idea of what equity and equality is. So we always say, or we hear, oh, let's treat everyone equal. Everyone should have equal things and opportunities and things like that. So equality means that each individual group or person has the same exact resources. So if you look at the picture, you have individuals who have all been given the same exact bike. And you can see, looking at the picture, that each individual is different. We have a woman who is in a wheelchair, we have a tall man, we have a woman, and we have a child. Something that they all have been given is a bike. They equally have been given the same resource. Well, when you think about equity, everyone's going to get a bike, but everyone gets the bike that's going to tailor to them and their specific need to get them from point A to B. So let's pretend from point A to B is their continuum of health, from an unhealthy state to a healthy state. So along this health continuum, we have to remember as healthcare professionals and as emerging and future healthcare professionals that sometimes patients may need a different approach. What worked for one patient in one community is not going to work for another patient in another community. So when we look at equity, we recognize that each person has a different circumstance, and we allocate the proper resources to help them have an equal outcome, right? So look at the picture again. You see the lady that was once in a wheelchair. She has a bicycle that is adapted to her disability. The taller individual, he has a bike now that he can actually stretch his legs on and get across the street in. The woman has a different bike, and now the child has a bike that's perfect for them. So as we frame this conversation, we're going to talk about disparities, meaning a particular group or population that has a poor outcome when it comes to a different health condition. And we're going to realize that there are some health equity issues around these different diseases. So health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. So you see in the picture, you have the people in the bike again, and just think about that framework as we go throughout the presentation. You can't talk about equity without talking about social determinants of health. I'm not sure if it's a public health term. I'm not sure if it has gone into like nursing and other health professions, but social determinants of health, as defined by Healthy People 2030, are conditions in the environment where people are born, live, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risk. So they're basically things that impact people's lives that aren't necessarily health related. They're more social related. And it's grouped into 5 different domains. The domains are health and education. So education, quality access to education. So access to education is a social determinant of health that can actually impact how you are able to overcome a different disease, or your even knowledge base of a disease. Quality to healthcare, your economic ability, your social and community contacts, as well as the neighborhood that you live in. So if your physician recommends that you walk 30 minutes a day, but you live on a busy road with no sidewalks, are we really going to walk? Probably. If it's not safe, if there's no street lights, probably not. So the built environment can have an impact on someone's health. That's just one example. Access to health care. Having access to insurance or being underinsured can impact someone's ability to seek health care. And also socially. So stigma is a big thing, especially when you're talking about infectious diseases. The stigma, or how you're perceived in your community if you have certain illnesses, that leads to people who are living with things such as HIV to remain silent and not seek help. All of these social determinants of health can impact the outcome of someone's health condition. And the magnifying glass that really highlighted social determinants of health and brought it home to probably everyone in this room was COVID-19. If you weren't personally impacted by COVID, you probably know somebody that was. It totally changed the way that we lived for about 3 years, well, since 2020, right? So this is March 2023, so we're officially, 3 years into this pandemic now? And, right? So in 2020, Dougherty County, rural Dougherty County, made national headlines, made worldwide headlines. Like people who, I tell people I live in Albany, I live in Georgia. They're like, oh, you live in Atlanta? No, that's not the only city in Georgia, right? So they're like, don't you live, now they know where Albany is. Don't you live in Albany? Was that on the news? And unfortunately, yes. We had the 4th highest rate of COVID, not in the nation, but in the world at one point, right here in Dougherty County. And unfortunately, we made the news a lot for the wrong reasons due to COVID-19 and how it hit our town. It hit like a bomb, as it was described in the New York Times. The Wall Street Journal talked about a funeral that took place prior to the outbreak, and it was just something that was in the headlines. But what the headlines did not talk about is the makeup of Dougherty County. What made COVID hit so hard in Dougherty County? It's not like the people in Albany are just COVID-prone just because they're COVID-prone. When you look at Dougherty County and remember those social determinants of health, you break down the county and you see 84% are high school graduates, which is That might be a little decent. That's pretty good. You look at the racial makeup of the town, 71% black, 24% white, 3.1% Hispanic. And you look at the poverty rate. 27% of the individuals in Dougherty County live in poverty. 73% have no access to internet. And where do most people get their information? The internet, exactly, for good or for worse, right? But it's a source of a source of information. So looking back at the social determinants of health, just remembering that slide and looking at those social determinants of health, we can see that there was a storm brewing here prior to COVID even hitting. When you think about the health of this county, the health of this area, that contributed to the hard impact COVID had on this area. When you look at Dougherty County and you compare it to other cities in Georgia and the nation, and these are national statistics, the life expectancy in Dougherty County is less. The life expectancy nationally is about 77 years and only 74 years in Dougherty County. The diabetes prevalence is much higher. Nationally, it's about 10%, and it's 16.3% in Dougherty County. The obesity prevalence, nationally, 35%. And here in Dougherty County, it's 41%. So not sure how far you all were into your clinical studies during COVID, but if you took care of a COVID patient, a lot of them had the same comorbidities. A lot of the comorbidities were diabetes, high blood pressure, obesity, and some other things that contributed to them possibly having a poor outcome when it came to COVID. So this is the data that kind of summarizes COVID for the past 3 years. COVID started here in Dougherty County on March 2nd, 2020. And here we are. My statistician, is Victoria here? She's a student at Albany State, too. Nope, I don't see her. Well, she does all my data for me. But she summarized the data. We went through it. And as you can see, when you look at the confirmed cases of COVID in Dougherty County, 68% of those were in Black, non-Hispanic individuals in the county. When you look at the racial breakdown of those who had COVID, you look at the age. Most of the cases were between 19 to 59 years old. And when you look at the deaths, unfortunately, 503 people lost their lives to COVID in Dougherty County. And I think before I said the slide, it was only about 80,000 people in this community. That's a large percentage of our community that lost their lives to COVID. And people are still dying from COVID. Not as much, but there are still certain populations that are still very vulnerable to COVID. So COVID is definitely a health equity issue. It's an issue that you have to look at the social determinants of health to determine how we can move the needle when it comes to COVID. COVID is not over. It's still here. It will be here. But we have learned to work under the conditions that we live in. And what kind of brought us out of the pandemic was the availability of vaccine. And once vaccine was available, we noticed that the populations that were highly impacted, where we had cases of COVID or even deaths of COVID, were least likely or more reluctant to be vaccinated initially when the vaccine came out. So to address that, we realized that in a perfect world, if we're giving out everything equally, we can open a clinic and say, hey, come down to Dougherty County Health Department, and everyone has equal access to get their COVID-19 vaccine. Well, we did that, and it wasn't working. Phoebe did that, it wasn't working. Everyone did that, it wasn't working. It was realized that you had to take a different approach to get the outcome that we needed. So within public health, and many other organizations did the same exact thing, we developed different equity task force, and ours was around vaccine. And basically, it was to provide education and raise awareness through grassroots efforts about COVID-19 and the vaccine. So we went out to the community. We leaned out into the faith-based communities because people trust who? Their pastors, right? So we went to churches and gave presentations during the pandemic. If they weren't meeting in person, then we met with them virtually to get the health messages out. We disseminated information at grocery stores. We set up pop-up clinics. So what we did is we leaned out into the community instead of having the community lean into us to get the vaccine. And we were able to write about our efforts and what we did. And were actually invited to present at a conference where we presented the tale of 2 mobile COVID-19 vaccine clinics, where we were able to determine that an intervention such as engagement with someone at a grocery store, talking to them one-on-one, asking them questions about why they were or weren't vaccinated, was something that would prompt them to get vaccinated. We had 2 different vaccine clinics. One day where we had someone providing education, providing resources, and talking to individuals. And then we had another day where we couldn't show up to do that, but the vaccine was available, and the difference in vaccination rates were pretty significant. So it lets you know that as a healthcare provider, sometimes it takes that extra intervention of seeing where that patient's at, meeting them where they are, and providing what they need to help them reach that best health outcome. So the next thing I'm going to talk about is World AIDS Day, or just HIV in general. And HIV is the human immunodeficiency virus. It's a virus that attacks the immune system, and it leads to the disease known as AIDS, which is acquired immunodeficiency syndrome. There's currently no cure for HIV. There are prevention methods, and there's effective treatment, so individuals living with HIV can live long, healthy lives. When you look at the rate of HIV across the state, the Albany area, which is Southwest Georgia District, is number 5 in the state of Georgia when it comes to new diagnoses of HIV at 27.4%. And most people think, oh, you live in a rural environment, you know, it's a little sleepy town, there's not a lot going on in this part of the state, but there is HIV transmission going on, and a lot of it has to do with individuals having stigma about treatment for HIV. And treatment is prevention, because individuals who are taking their medication, they can be non-detectable, and the likelihood of transmitting HIV to others is very small if they are under treatment and their viral loads are suppressed. When you look at the racial and gender breakdown of HIV, you can see that most of the cases in 2019 were among men. Most of them were black men. Most of them were black men who have sex with men. And you can also see the age distribution when it comes to the new cases of HIV. But right behind men were black women for new cases of HIV. So when you have your patient and you're taking a history, you can't shy away from the sexual history when you're talking to your patients. All my nurses in the room, I want you to hear me. You have to ask the patient those questions that may be a little uncomfortable for you, but you're asking these questions because you're trying to determine what risk factors this patient may have so that we can provide the appropriate education, resources, interventions, and prevention that they may need to have a healthy life. Whether it's someone living with HIV and it's not in care, if it's someone who is at risk for HIV, making sure that they know what resources are available to them. So we know that condoms can help prevent STDs and HIV, but everyone doesn't necessarily feel comfortable walking up to someone and saying, hey, can I get some condoms, right? So during the pandemic, public health implemented a program to meet people where they are, to give them the resources that they need. And we're like the Amazon Prime of condoms, right? So you can really scan the code, and don't be scared. Scan the code, and we will actually send condoms to your home. Oh, scan it. But we will send condoms to your house, right? So, if you don't need it, you might know someone that does, but it's a resource. So it takes that fear of someone walking into the health department or walking into student health services and saying, Dr. Phillips, can I get some condoms? You don't even have to ask anymore. You scan it, we'll mail them to you. We also mail lube. We mail information on how to properly wear condoms and how to dispose of them. And we even have a home HIV testing program where we will send a HIV testing kit to your house that you can do. Everybody knows how to test now because you do your COVID test, right? Well, there's an HIV swab you can do at home and you get your results in 20 minutes, right? So we want to make sure that people have the resources that they need to know their status. And if they know their status, then they can take the appropriate measures. So it's just making sure everyone has the bike that they need to have the best outcome. And it's so important because 1 in 7 people with HIV have no idea that they have it, right? Because they've never tested. So many providers, I could just talk about my own provider. They never asked me, do I want to test for HIV, except for the times that I've had children where it's mandated by law. You know, it's a conversation that a lot of providers shy away from. So who should be tested for HIV? The CDC recommends that everyone should be tested at least once in their lifetime between ages 13 and 64, depending on their risk factors, right? So HIV testing is for everyone. You can get tested at your local health department, where it's always free and it's always confidential, or you can go to your private providers. So that's good information to have for your patients. And patients should also know what they should do if they have a negative result. You're negative, but you're negative today, right? So if there's different risk factors or different high-risk behaviors that a patient could be engaging in, then we want to educate them on what they can do to keep their status negative. Or if in the event that they are positive, what can we do to quickly get them into care? Because HIV care is free to about 99% of the population. Monetary resources are not a factor in the ability to provide medication to treat HIV. We have a public health program that provides medication. In our district, they see a doctor, they get on their medication, and we deliver the medication to their home. It comes in a box that looks like anything else that you get from Amazon. So no one knows. You eliminate the barrier of walking into a pharmacy and risking seeing your neighbor or your church member and thinking that someone knows what you're picking up at the pharmacy. In addition to the home HIV test, we also do rapid testing. We do rapid HIV testing in the community. We also do it at the health department. And with the rapid HIV test, the INSTI test, people get their results in 1 minute. So you quickly get a test result that, if negative, we take it as negative. If the rapid result is positive, then we follow up with a second test, a blood draw that we send to the laboratory to confirm that positive. And that's the flyer for our take-home test. So PrEP. A lot of people don't know that PrEP is available and is a pill that you can take every day to prevent HIV infection. So if someone is on PrEP, which means pre-exposure prophylaxis, means you take this medication, it's an antiviral, and you take it once a day, and it will prevent you from acquiring HIV in the event that you are exposed to it. And PrEP, there's a guideline that we use to determine who's right for PrEP. So that's why it's a good idea to really ask those questions when you're doing a sexual history on your patients, to determine are there different resources. Because the worst feeling in the world for me as a nurse, especially a nurse in infectious disease, is if I have a patient one day that, say I didn't ask them these questions, I see them a year later, and then they possibly have a diagnosis that possibly could have been prevented if they were given the proper resources to obtain the medication that they needed. And PrEP is also available at your local health department. PrEP is also available through Albany Area Primary Health Care here in Dougherty County, as well as some other private providers that may be doing it. So with HIV prevention, we know that condoms work, we got PrEP, we have testing, and we have medication. We have a toolbox to fight HIV to help prevent or decrease those disparities that we saw in Southwest Georgia. Nothing about the population or the actual person in Dougherty County makes them more susceptible to HIV. It is the environment that we live in, the stigma that's in this area where people don't have these open conversations, or where individuals are afraid to seek intervention or treatment that contribute to the rates of HIV in this area. So we are really fortunate in public health that we have an awesome, great collaborative relationship with Albany State Student Health Services. And they allow us to come on campus in addition to other places that we go in the community and offer free HIV testing. In the picture you see, You see my intern who's in the building, Ty. Hey, Ty. He's going to stand up. Okay. Who's a graduating senior in the healthcare management program here at Albany State, but he's also an intern with me and has been helping plan HIV testing events on campus. So not only is public health here, but we also like to involve our priority populations. As young as I think I may be, you know, I've been out of college a couple of years. And, you know, what was right when I was in college may not be the thing that it is now. So it's important that we utilize the youth, the resources that we have, and we pick their brains so that I can make sure that the efforts that we're doing match the population that we're trying to serve. That's a picture there of my staff doing HIV testing. It's not a real picture. They're both my staff members. Nobody's confidentiality was broken. And just last month, we had our first HIV/AIDS awareness town hall here on the campus of Albany State University. Dr. Williams, who is the medical director for student health services, served on our panel, along with Alandria Bennett-Reed, who works as a nurse practitioner in your student health services. Christian, who is a peer advocate and leader on campus, served on our panel, along with other public health staff. And we had a turnout about 50 students in the ballroom. And we talked about HIV and provided education and resources to them. And we also coupled that event with testing. So we want to make sure that every time we're educating someone that we have an opportunity to offer testing as well. And we were really excited about the presentation that, you know, if you look at the pre-assessment and the knowledge that the participants said that they had around HIV, and then you look at the post-assessment and you can see their knowledge base grew. And that's what you want. You want to be able to educate people so that they can be informed and they can make the best health decisions about their health. So you can't talk about HIV and not talk about STDs or STIs. And if you look at the map of Georgia, each county is color-coded. And the darker the color, the more prevalent STDs are in that particular community. So even if you're not from Dougherty County, you may or may not be able to find your county on the map, but you can see where there are concentrated rates of sexually transmitted diseases in Dougherty County and other parts of our state. And when looking at the case rates of STDs in 2021, there were over 1,700 cases of STDs, and about 70% of those were among women. And if you look at the racial breakdown, you can see 4% were white and 87% were black. And you can look at the age distribution, and you can see most of the cases were between 18 to 24, which is what we consider college-age students. Not necessarily it represents this campus, but it represents the demographic of those who were on the campus. So STD and HIV is a huge conversation. And STDs are so important because being diagnosed with an STD significantly increases your possibility of contracting HIV. So we want to make sure that we prevent STDs so that we can also prevent cases of HIV. So we also, in the recent news, have heard about monkeypox. And it was a lot more prevalent, I would say about 3-4 months ago. But it was something that kind of even hit our area hard, and a lot of people really don't even know about that. But the symptoms of monkeypox were like a rash, flu-like symptoms, swollen lymph nodes. And monkeypox, although most people think it was sexually transmitted, it was actually close personal contact. So it was not necessarily a sexually transmitted disease. You could have a roommate or a housemate, or a mother could be caring for a child, and there could be transmission of monkeypox. So it was person-to-person transmission. And these are pictures of what the cases actually looked like, and that's pretty mild, actually. We had some that had some more significant lesions on their body. But when you look at monkeypox in Georgia, there were about 1,900 cases of monkeypox across the state, or Mpox is the abbreviation that is recommended at this point. Most of them were among men, black men, and the median age was actually about 35 years old. And 60% of those that were tested positive for monkeypox were also living with HIV. So here we have a double whammy of 2 infectious diseases affecting a particular population, and realizing that there is an intervention that needs to happen because monkeypox is actually vaccine preventable. There's a vaccine that individuals can take to try and reduce the likelihood that they will get monkeypox. So here in Southwest Georgia, we received over 50 different people that were suspected of having Mpox. And out of those 50, we were able to confirm via lab 23 cases of Mpox throughout our area. Most of them were men, and most of them were about 36 years of age. But we also had cases among younger individuals, and we realized that that was a population that could potentially cause a lot of spread of monkeypox just due to the social nature of people in that age. So when Mpox vaccine came out, there was a criteria, and we quickly realized, once again, like with COVID, it was sort of similar. People were reluctant to become vaccinated. They just didn't have the information that they needed. So we realized that we needed to reach out into the community, go out to different places, educate about Mpox, and provide the actual vaccine. So one of our places that we were able to do that was here on campus after we collaborated with Student Health Services, where we were actually able to come on campus, provide education, in addition to HIV testing, but also provide Mpox vaccine. And it was a really good turnout. We also depended on student leaders, and I have to thank Ms. Alandria Bennett-Reed. She's not here today, but her students that she has trained and have gone through this process of becoming peer health advocates were really instrumental in helping us get students that met the criteria vaccinated. And the good work that was done here were shared as best practices just 3 weeks ago at a symposium where we presented Taking a Shot at the Outbreak, Mpox Vaccine Clinic at a historically black college and university. We presented this at a conference that both public health and ASU staff were able to attend. And the presentation was very well received from those who wanted to learn how they can go out into the community, reach vulnerable populations, and provide resources that they need to live healthier lives. So when you look at health equity, the strategies that we implemented were, we used data. So we used the data to look and see where we needed to go. We look at census tract data. We can track just about every case of infectious disease to the block or to the house of where they may have been, where they actually live. So we can see where we need to go with different interventions, and we can see what intervention needs to happen here versus here. What we do on the east side of Albany may be a little bit different than what we do in West Albany, or what we do in Albany may be a little bit different than what we do in Cairo, which is part of our district as well. We fostered meaningful engagement with the community with diverse leaders, and this is really important. A lot of times we work in silos, meaning we don't reach across the aisle and try to see what someone else is doing, or we're all trying to reinvent the wheel opposed to working together. We took the limited resources, because everybody's working with limited resources that we had, and we merged together, and we were able to make a good outcome when it came to vaccination rates for COVID, when it comes to getting individuals tested for HIV or even treated for HIV. And we led a culturally responsive approach. You want to make sure when you're doing outreach and you're planning your interventions for a community that you involve the members of that community, right? So I'm not a college student. I don't know what may be happening on college campuses, but guess what? I found me an intern who did, right? And, so using those types of resources. Or if you are doing an intervention that involves a faith-based group or into churches, then involve pastoral leadership or members of the congregation of that faith-based organization to be on your planning committees so that when you're planning interventions for a community, they are tailored to that community. Everybody has the bike that they need to get across that street. You want to reduce stigma. That's the biggest thing. Even with COVID, and initially people had COVID and was afraid to tell other people that they had COVID because they felt that they were going to be treated differently. Well, that's the stigma that comes along with HIV, even having sexually transmitted infections, and even with emerging infections such as monkeypox. There's a stigma associated with some of these illnesses. So these are just some strategies and some examples of how health equity impacts infectious disease. But don't think that health equity is only apparent in infectious disease. I could do a talk on chronic disease, diabetes, high blood pressure in this area. We could look at rates of amputation in this area, and you will see some of the same disparities when it comes to people living in Southwest Georgia or Georgia in general. We're called the stroke belt of the state because of the rates of strokes. So health equity issues, they expand beyond infectious diseases, but infectious disease is my specialty, and I was invited here to talk to you about that, and I thank you all for the opportunity today. Thank you.
That was amazing. Thank you so much, really. Don't leave yet. We have question and answers. So I'm going to take 5 to 10 questions until we go. So who has a question for our lovely speaker here? I know y'all got some burning questions after. Yes, sir. Come to the mic down here, please. Thank you. Y'all think about some questions or concerns you might want to ask our expert here, even some praise, if you have some praises or comments about on-campus activities that you've seen or witnessed to. Yes, sir.
First of all, I want to tell you thank you. This was a beautiful presentation, and some of the things I've talked about with some of my students in my class as well, so I'm glad to see it see it being reinforced. Quick question about some of the data.
Yeah.
Could you provide a little more context on what rates mean in public health?
Sure.
Versus, because when in biology and with my students, when we think rates, we're thinking out of 100 or percent out of 100. And I saw the state where it said 27.1, and it didn't really say whether that was percent of new cases in Georgia, in Albany, in Georgia, out of whatever. And so could you provide a little more context for those data for those of us who don't usually talk about things in a public health perspective?
So with public health, most of our data is per population. So it's per 100,000. And that's how we are able to compare larger cities, smaller cities, no matter where you are. It's per population. So we multiply it by 100,000. And that's how we get our rates. Does that answer your question? Okay.
Hi, thank you so much for that presentation. That was so informative and interesting. A quick question. Throughout the years with the data, I know it probably changed with the COVID-19 pandemic a little bit. As far as like HIV rates and things like that and racialized health disparities, has there been an improvement throughout the years, or has it stayed the same or decreased? I'm curious about that.
So, it's a good question. In preparing for this presentation, we were for STD rates. I think we were number 4 in the state, and now we're 5. So it changed just a little bit. I think the Valdosta district may have surpassed us just a little bit more. But when you compare it to the other parts of the state, we still have a significantly high number of some of these infectious diseases. But data is about 2.5 to 3 years out. So the real impact of this pandemic and how it has impacted us it hasn't been seen yet because the data has not been released yet. So that's a great question and something to kind of look at as new data is released. You're welcome.
Hi, thank you again for your presentation. I really enjoyed it. I have like a more personal question. How did you get started in public health and kind of what drew you to it, and what was your experience doing your master's program in public health?
Okay. So I think I was one of the rare people that when I went to nursing school, I knew I wanted to be a public health nurse. Like some people like the ER, they like, labor and delivery. When I did my public health rotation, I said, this is it. Like I knew that's what I wanted to do. So I did my bid of med surge about a year and a half or so. Y'all can have it. Um, gained a lot of knowledge. But honestly, I had the privilege at Florida A&M University to have a wonderful community health instructor. And I think it's really important for colleges and universities to have instructors that are very knowledgeable in the area. And she was a public health nurse teaching this community-based class. And I think it made all the difference for me. So I went in, by the time I graduated nursing school, I knew that at some time I wanted to be a public health nurse and quickly was able to pursue that. And then my master's program in public health, once I got into the profession of public health nursing, I was kind of torn, like, did I want a master's degree in nursing or did I want one in public health? Like, what did I really want? But the art and the science of public health is what really drew me and made me make my decision to get my MPH opposed to maybe my MSN. And I have always had a passion for infectious diseases, and so that helped guide my pathway of majoring in communicable diseases, where basically for 2.5 years, that's all I studied was the various infectious diseases. So hope that answered your question.
Hey everyone, I had a question about when you was talking about where y'all do rapid testing. You said at the health department, at the rural clinic, and you also do it on campus, right?
Yes.
Okay, that's all I had.
Yes.
And
Okay, so
Albany Area Primary Health Care also.
Summer said she's going to announce the new testing. I think we're on the 14th.
The next testing for, we call it Know Your Status KISS. KISS is next Wednesday. It's going to be on West Campus. Is that right, Summer? Next Wednesday on West Campus from 10 to 2. We do chlamydia, we do gonorrhea, and we also do HIV. Mm-hmm. We have another provider that comes in to help us do the HIV piece.
And we also do large-scale testing events. Typically, we do it on What's Up Wednesday about once or twice every semester. And we usually get a really good turnout. Anywhere between 50 to 60 students test at each testing event. So, but if you can't make it to one of those dates, you can call us at the health department. My number's up there, yeah. And we'll figure out how to get you tested if we need to.
Hi, thank you for your presentation. I really did appreciate it. I have a question about the disparities. I know that there's a lot more than just the education. You did mention there were some environmental disparities, so that could be income, that could be, like you said, education. So for people who are not in schools, they don't visit the local health department or they don't really go to the hospital unless it's super emergent. How do you reach out to those people who don't have monetary who don't really have money to like get out the house. People who stay in the house all the time because they don't have insurance or they don't have anyone in school. They don't really have family. How do you get to those?
So that's a good question. And it's something that we're honestly always trying to tweak to find the best method to reach those who aren't necessarily coming into our doors. So, for example, with young adults, social media is a way that we reach a lot of people. And initially, I think people kind of shied away from social media, but we have really been able to use it as a tool to get public health messages out. And you can track everything in social media. You can track your metrics. And we look at it's called a click-through rate. I don't know if anybody knows what that is, but you can tell by how many people clicked your ad to get more information. And we realized that some of our highest performing ads were those around infectious diseases, that we put information out there about condoms or testing or HIV prevention. And we don't stop at just Facebook and Instagram. We go to social media platforms that target priority population. So if we're looking for men who have sex with men to get a health message out, then we're going to go to the dating apps like Grindr to put those messages out. So social media has been one, and also leveraging partnerships with community based services organizations so that we can get information out to them. So, for example, when people weren't coming in to receive services, we started mailing out WIC vouchers. Y'all know what WIC is? Women, Infant, and Children. It's a program that provides milk and cheese and resources for mothers that are pregnant and those that are postpartum a couple years. But we mailed information out. So what touch points do we have to reach patients? And leveraging and using those to get information out are just two examples. A certain population still watches the daily news, WALB, News Channel 10, Carla Heath Sands. We can get with someone like that to get a health message out. And a lot of times you do all of that to get one message out, if that makes sense.
Thank you.
You're welcome.
There you go. Yeah, so just an answer to her question. The apartment that I live in, Albany area, they come there every Wednesday for screening. So the people that can really go out, like she was asking, they're able to come to the leasing office and, get screened. So it's done every Wednesday in my apartment. And I have a question about the HIV rapid testing, about you getting it, they mailing it to you. I saw that in a YouTube news, and I called the health department. They said there's nothing like that. They can't just mail HIV rapid testing to your home.
You called Doherty County Health
Yes,
Department?
ma'am. Yes.
Well, call me, and I'll make sure you get one. Yeah.
And her number is on the screen, so take a picture of the screen. Any more questions? Okay, you guys might get a pop quiz this week in your class. You have any questions? You got the expert here. You better ask while you have a chance. Pop quiz, pop quiz.
So, okay, let me ask a question. Call and response. So, as emerging health professionals, can anybody share anything that they may do differently as they interact with patients when they're educating their patients, or maybe even your colleagues? Like, what I want you to take something from here and be able to send it to someone else or teach it to someone else. So, does anybody have a takeaway home point that they might want to share with someone else?
So something that I have to do on a daily basis, I think, first let me start with, in all of our fields, it's actually important that we remain professionals, and I completely understand that. But there are some times where I find meeting my patient where they are, not just physically, but even in the way that I speak to them. Sometimes they don't want to hear someone that speaks properly. They're not listening. Sometimes they want you to come down and use some lyrics from a rap song that you may know, just to relate to them, kind of laugh with them about what they're talking about. And to others, it may seem like, oh, that person is being unprofessional. But a lot of times I find that I really do reach my patients when I meet them where they are, when I talk about what they want to talk about and talk about it the way that they want to talk about it.
Right. That's a good point. When you think about health literacy, I think the recommended reading level when you're sending out a health literacy or even a health message is like a 5th grade level. So we don't have to talk like we have, degrees and whatever in order to reach our patients. And sometimes you do have to quote Cardi B, to get a response from your patient. So it's possible, yes.
I just wanted to kind of piggyback off of what she said with patients. With me, it ain't really always patients, it's students. So how do you get students to come get tested for HIV without making it sound or look weird or something like that? Or a lot of people say, well, I ain't doing nothing like that to, get tested. You have to, not I ain't going to say dumb it down, but it's just like you have to, remind them the importance and, like, educate them on why they should, and also, like, try to sound cool with it a little bit. Just, it ain't going to take that long. I always say it don't take that long. And you can persuade them to come in, but that's what I feel like a lot of times we have trouble with getting folks to come in because we can't relate to them. Mm-hmm. So that's a tip.
Hey everyone. One of the things I had to learn as someone who's trying to get more educated on public health, infectious diseases, but also as someone who's studying to be a nurse, is that first, as someone who is going to be, I guess, assessing patients, and so you have to address your own bias, even if it's not something that's rooted in ill intent. Yes. Misinformation is everywhere, and you won't know it until you're addressed with, presentations like this. where you're getting a professional who's speaking facts. So even if you're addressing something that you've never seen before, have no experience with, or you have a bit of bias or stigma, even if you're like the healthcare provider talking to a patient, I would just say don't be afraid to ask questions. Don't be afraid to admit, and I guess in a professional way, when you need to do more research or you need to, I guess, find out more information, because you'll never be able to properly assess your patient if they feel like you're the one judging them, especially if you're not meaning to do that intentionally, if that makes sense.
Yeah, good point. And one negative interaction with the healthcare provider could impact a person's whole perception of healthcare in an entity or, in a community. So that's a very good point. Yes.
And we have to remember that our patients know whether or not we sincerely care.
Yeah.
You can't fake a passion, so they're going to be able to pick up whether or not you're sincerely concerned about them. And if they feel that you are, they'll be more willing to be more compliant as a patient.
Mm-hmm.
All I genuinely want to say is that I feel like we should find a better way to promote it as far as with our men, because our men don't go see doctors as much as women do. For example, my granddad, he found out he had colon cancer because he just wasn't going to the doctor. He was just working all the time, never going to the doctor, and he found out late, and he was almost too late. And I feel like with our men, they're more like, it's just a man thing. They just don't want to go. I'm going to take care of myself. I'm all right. But I feel like we should find more ways to help promote our men to go get seen about whether they're sick or not. Just to go like us women do. We just go just to go. So.
Yeah, that's a great point. I agree. All right. Well, thank you for your time and your questions.
Thank you so much, and thank you to our volunteers that helped tonight as well. Have a great night.